Hello, my name is Janet and I'm publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision and continuing professional development. This year, medicine celebrates its 50th anniversary. In honour of this, we've put together a collection of podcasts recorded by the journal's chairman, Albert Ferro. We hope you enjoy them. If you want to find out more about medicine, including how to subscribe, please visit www.medicinejournal.co.uk.
Hello, and welcome to the latest in the medicine podcast series. My name's Albert Ferro. I'm a clinical pharmacologist at King's College London and also chairman of the Editorial Board of Medicine. And I'm delighted to be joined today by Professor James Teo, who's also at King's College London, based at King's College Hospital. He's a neurologist and director of data science and artificial intelligence. More of that in a few minutes. But James, you're very welcome.
Yeah, thanks. Thank you for inviting me in, Albert.
Can I start off just by asking you to give us a brief outline of how you got here, your career so far?
Okay. I think this applies to most people working in this, clinicians working in this field, is that they kind of stumble upon it in a very roundabout way. So I went to university in Oxford, then did my clinical training in London, and did my PhD in clinical neurology. And I didn't have really any particular training in informatics. I used computers, obviously. I used technology for day-to-day work. During my PhD, I did it in brain recordings in patients with strokes and movement disorders. And then I progressed from there into clinical work. But along the way, I picked up a lot of tools around statistics and handling of data. And I have a personal interest in using computers. And from there, when I started my consultant job, I began to try to use those skills in the NHS environment. And I discovered all the barriers as well as all the benefits. And that's how I ended up in this position. And we basically started off with little hobby projects, which eventually grew into things in which became powerful technologies.
So you initially started applying it to your work as a neurologist, but it's kind of mushroomed since then. Is that fair to say?
Yeah, that's pretty much fair to say. And after a certain amount of mushrooming, I decided that I didn't want to just confine its use to my clinical domain or my clinical specialty, or to my hospital, but to actually share it more openly, because I felt it was extremely the frustrations I had were frustrations shared by everyone, and I felt that things would be a lot better for everyone if these things were shared.
I think we might come a bit later to some of the frustrations and things that have happened since then and things that still need to be done. I'd just be interested to know from you how you managed to run these two parts of your career in parallel: your work as a neurologist on the one hand, and your work on digital medicine on the other.
I think for a period of time, I ran them, as you say, in complete isolation from each other. And in fact, most of my early work in informatics and data was not remunerated. And not planned out. But over time, it became very clear to my colleagues and managers that this work was valuable and valuable at a organization-wide level. And so they began to raise funds to essentially buy out my time to allow me to spend more time on this. And obviously, the bargain is that I do it for everyone rather than do it for myself. And I think that's a good way of handling it. There is a large element of making sure that you have to balance out your time between your clinical hat on and with your informatics and data hat on. But I think it's necessary, because without the clinical reality, you do not you end up becoming quite divorced from what actually problems people face on the ground.
Absolutely, couldn't agree more. So thinking back when I was a medical student, junior doctor, digital medicine just wasn't a thing at all. I mean, I think computers exist, but we didn't have electronic notes, we didn't have e-prescribing, didn't have any data stored on computer at all. So things have obviously changed a lot since then. E-noting is now so widespread, as is e-prescribing, and the use of computers in medicine, as well as research, but in clinical medicine as well, has obviously increased a lot. Perhaps I'd just be interested in your thoughts on how things have evolved and how you see things evolving from here, really.
So I can say that one of my slight kind of things that get me a little bit anxious is just the idea of talking about digital medicine and digital health, in the sense that we don't talk about digital banking, we just talk about banking. And as a result, I think to a large extent, just adding the word digital in front of health and medicine, it's essentially just adding a word to make it sound trendy. I think we're doing things that is part of the natural evolution of the industry in the early 21st century. And so it's not digital in the sense, it's like, I think 20 years ago, everything was E this, E that. Then 10 years ago, everything was I this, I that. and now it's digital this, digital that. And very soon it'll be something else. But so my thoughts really is that the word itself is a fad. However, the incorporation of these tools, these technologies, these working practices are all part of just the natural progression of healthcare.
Yes, so you would be in favor of not labeling it in any way. It's just part of medicine now, really. Okay.
Correct.
Okay. So one of the things about the whole sort of computerization of digital records and so on, sorry to use the word digital there, but the availability electronically of patient records is that it's obviously created a lot of opportunity and capacity for new types of research to be done in large patient groups. And the NHS, of course, is a wonderful sort of foundation for doing large-scale patient research. And so being able to access patient data has been very useful in that regard. But on the other hand, you'll be well aware that there are patient groups who are a bit suspicious about availability of patient data in that way, in particular the ethical issues around confidentiality. So again, I'd be interested in your views really as to the pros and cons of having patient data available in this way.
So I think certainly the data was always there. It wasn't in a format that could be handled at scale. It had to be done through human manpower, basically, and it's lots and lots of students and analysts manually going through things and tabulating it. This process has produced huge amounts of success in the 80s and 90s for a variety of large-scale epidemiological research studies and population health work. However, that is not easy to reproduce, and it's extremely costly to reproduce over and over again. And so as a result, I think the main pro is that this kind of work can happen at a much more scalable fashion, in that you might be able to do a rerun some of these epidemiological studies easily. You can monitor whether the truths are still true and whether or not new findings can be found. And in that sense, I think the COVID pandemic really highlighted the value of working with big data in a very agile and almost real-time way. I think all those dashboards that was being shown up in news conferences and such just highlighted the role of being able to handle large-scale data in real time. And I think there is obviously the scale at a country level, or even at the hospital level or a district level, but this big data work can actually be scaled down to the micro level, to the patient level as well, because some of the things that we find, it can be used to target interventions towards individuals or populations who are highest at risk. And so this during the COVID vaccination period and during the various other treatment parameters was being developed during the COVID pandemic, showed that we could target treatments and trials to individuals for their benefit. Likewise, for patient safety, for regulation of medical devices and medicines, this is only possible if we have large-scale data and to track patient safety events in near real time. So I've expounded on the pros. I guess with regards to the cons, I think the key bit really is that there is that the people whose data users have the ability to opt out essentially. And I think this is a foundation to the Caldecott principles. There is a duty to share as well in the Caldecott principles, but there is also a right to autonomy to be able to express dissent. And I think building the ability to express dissent is a key way to making sure that this is ethical.
Mm. Good. Thank you, James. And I think the example you quote in particular will be very clear to us how epidemiological data was used during the COVID pandemic and how useful that was. So that's great. Thank you very much. I alluded to the other part of your title, which was artificial intelligence. And this is obviously something that is of great interest to many people and very topical at the moment. And then, of course, there's machine learning as well, which is kind of related but slightly different. And I wonder if you could just explain to the listeners and viewers what we mean by AI and machine learning, and what they are, what the difference is, that sort of thing.
So machine learning is essentially using machine algorithms to detect patterns and learn from an amount of data. It detects these patterns, and these algorithms then calculate a particular way of representing the information in the algorithm, and it learns with more data it gets. Machine learning has been around for a long time, and various types of algorithms have existed for decades. What's happened some of the earliest medical statistics use logistic regressions and such, which are actually forms of machine learning. What is different in the modern era is that these statistical or machine learning techniques have become so cheap and easy to perform, and extremely powerful at detecting patterns from large amounts of information. So the more modern techniques involve neural networks. So these are algorithms which are modeled after the human brain, elements of the human brain, and how it detects patterns in the visual cortex. And this particular way of doing algorithms with neural networks has made people end up calling it AI, because it's kind of human-like in the sense because it's copying the brain. It's not really human-like in many ways. There are many artificial elements to it, and it's only one tiny component of the brain that it is copying. It's, I guess, in terms of, it's in my title because is one of those trendy words that has come up in the last few years. I think the key bit, my personal view is that it's better to call it machine learning and data science. It is actually a revamped form of classical statistics.
Okay, that makes it a bit more understandable.
Yeah.
Could you maybe just give an example or two of where it's being used, perhaps in research or even in clinical practice? And you might even want to talk about your own research a little bit.
Yeah, sure. So I think with AI work in healthcare, most of them are broadly divided into the type of data that feeds these algorithms to make them detect a pattern. So a particular algorithm or AI is only as good as the data it's given. So one area that I'm personally interested in is what we call natural language processing, which is getting AI or machine learning to be able to read and understand and to respond in a human-like way in language, in normal language, not computer language. Then there is machine vision. So basically getting computers to see, to interpret images and moving things just the same way that you and I interpret it, so that we don't need to train it in a particular way. It trains itself to a large degree. And machine vision is obviously most useful in radiology and pathology. Then natural language, as I said, is useful for human interaction with the computer. And then a large element around healthcare research using AI is actually using health record data to do risk stratification. So using the machine learning to detect patterns in someone's health record of risk and to determine their likelihood of developing condition Y or condition X, or the complication Y, or dying, or the effect of an intervention, basically. So this is kind of a prediction based on data. This last bit is an area which is actually just a natural evolution of a lot of risk calculators that doctors already use. It's just using thousands of variables rather than 3 or 4. And so that aspect, however, is much more complicated because it requires the data to be in a much more standardized form than most of how the NHS generates it. So those are the kind of the 3 broad areas. And I guess the last area which we are still learning about is genomics and drug discovery. And those are mainly in a research context in which you use machine learning and AI to try to read the genome for you, to interpret, to provide interpretations, or to model out whether a drug is likely to work or a particular gene is supposed to do something. So those are the 4 areas. I must admit that in most academic research focuses perhaps on the latter categories, whereas I think the ones which are nearest real world use, and some of them already have commercial products in the market, are around machine vision and natural language, because those are areas in which we have the NHS and healthcare produces large amounts of that data.
Certainly, it sounds like the possibilities are huge. I want to take you into an area of, if you like, philosophy. So taking you away from the science slightly. And one of the things you often hear from people is, well, we want to be treated by human doctors, not by machines. I don't think you're in any way suggesting that machines are going to take over from doctors. I think most of us would say that having computers assist medical professionals in diagnosis and treatment has to be a good thing. Do you yourself see any issues, any problems, any dehumanization, if you like, of medicine by the use of AI and machine learning and so forth?
I think the technology itself is not dehumanizing. I think if it is misused in a way that it's not, then it is potentially dehumanizing. Examples could include chatbots. I think there was an era 5-10 years ago when chatbots became a very popular thing to be used for triaging. I think it's kind of fallen out of favor in many regards. We've dealt with chatbots when handling our bank affairs and such. We don't particularly like dealing with them.
No, certainly not.
And I would say that that's one way in which AI has been misused and has caused dehumanizing effects. And it's because really, I think it's people have seen, people back then misunderstood how to use it. And so they're using it in a way that where AI is not actually making the most of it. The things that AI makes the best of is doing simple, repetitive tasks which human beings are not very good at doing and that do not rely on human beings, human communication. So, transcribing information, translating document types from one document to another, labeling things, passing letters from one person to another. All these things computers are extremely good at, whereas human beings are perhaps would find it a bit tedious. Yes. And so those are the things that we probably should be getting AI to help with first. So assisting radiologists to identify images or labeling bits of the images for them, processing it so that that it is delivered to them in a way that they can handle in a more efficient way. So in that way, I do not think it's dehumanizing as long as you allocate it to the correct part of healthcare, trying to put it in the in the patient-facing part of healthcare, I think can be problematic, and certainly it would not be the first thing I would target in the technology revolution.
Sure. So what you're saying is that it depends how it's applied as to whether that's going to be the case. And I guess that takes us on to something you mentioned earlier on, and that is regulation. And obviously regulation is going to be an important part of any technology or devices that are developed. I'd like to get your views on how important that is, and in practice, how regulation will happen.
So yes, regulation is necessary. The issue, I think, is the old regulatory frameworks don't always work very well in handling software. So there are medical software as a device, and there is regulatory approaches to handling it. But a lot of machine learning algorithms are software which have been found to have some differences from traditional software and medical devices in that they can change over time, either if you allow them to learn, for example, or if it's detecting, if the real world doesn't represent what it was developed for, if the real world changes in some way. So if, let's say, you had developed an AI in 2016 for detecting pandemics, you'd be very good at detecting flu. And if in 2020 that algorithm was then used in a new pandemic, the reality has changed, and the algorithm no longer is good enough. And so regulation often is too slow for that. The conventional regulatory approach is too slow for that. And so one has to work out a way in which regulation works in an embedded fashion with these algorithms. So there is a trend within other industries called ML ops, which is sense of machine learning ops, which is basically about handling AI models, detecting version, controlling them, detecting when they fail, detecting when the error messages, tracking it, detecting when it drifts, detecting biases. All that is being used in other industries. They're not necessarily being used in a human setting, but they are interested in how we handle all these variety, this little zoo of many different types of models. And I think we have to move our thinking about healthcare AI into that framework. And whether it be national regulators or organizations or the manufacturers who manage these there's ML ops, there's regulatory aspect of it and quality control aspects.
So it sounds like the regulatory aspect is going to be very important, but we haven't quite got there yet in terms of what.
Yes, I think at the moment, we're working on a traditional national framework, which is very kind of MHRA does it remotely, and they come in and do inspections every 1 or 2 years, and people self-certify things. A lot of these things that I'm not sure that will work in the long term.
Yes, we'll have to see how it all works out. Coming back to everyday practicalities, my experience of switching on my NHS computer is that it uses outdated software quite often. It takes 10 minutes to boot up, and it takes ages to get anything done. The vision you present is a very different one, where machines can do everything for you, whereas a lot of us have difficulty getting even the basic things done. How do the two square up to each other?
So I think a lot of this relates to the way the NHS has handled software and data, and it's not handled it in a way that is very agile and very scalable. And so in other industries, they've done it differently, and they've not handled large procurements. Large procurements of software ends up procuring software which is outdated already by the time you bought it. A lot of these procurements as well have to fit different types of software together, which are not very compatible, and they have to force them together. And so as a result, the NHS has ended up buying bits of kit which are outdated, and then trying to make them work in a very clumsy way. And this is related to the way the hospitals are required to procure the software. The other factor is that the data that NHS generates we generate a lot of data, but the data we generate is not high quality. What is high quality data? High quality doesn't just mean accurate. High quality means that it is standardized and structured. And that standard is what we call interoperable, following certain formats in which machines can read very easily. The NHS has not handled that very well. And so as a result, most of the systems can't read the data people put in because the data is not of high enough quality. So that mismatch between that far off vision, this utopia that I paint, and the reality is that there are lots of things to sort out to make it possible. Most of these things are very foundational, and foundational in the sense that they are not even they're not visible to anyone dealing with a computer on their office desk. They're all done in the server rooms and in commercial procurement contracts and virtual machines and connections. And all this, just because it's not physical doesn't mean it's not affecting everyone, because clearly it is. Other industries have managed to do this by forcing people to follow certain standards, or the organizations wanting to follow certain standards and converging to certain standards. The NHS, unfortunately, has taken a long time to do that. It's getting around to it faster than more recently, but other countries, certainly in the US, they spent a lot of time around these standards because these standards were pushed upon them, not by the government, not by the hospitals, but by the insurers. Because the insurers wanted the data to be interoperable and the systems to work fast for them.
Yeah, absolutely.
So the person who pays the bills ends up making it fast.
Yes, money talks as always. So hopefully the NHS will get there in time. I want to finish off, James, by taking you to an area that I know you're also very interested in, and it means a lot to you, and that's medical education. And to say that when I was a medical student, we didn't learn anything about digital science, computers and so forth. It wasn't a thing at the time, as I mentioned at the beginning. And I'm not really sure that medical education has really changed that much in the 30 plus years since I was in medical school. So I wonder whether you think we're doing enough to teach, and I know you don't like separating this digital science bit from medicine itself, but I think it is separated in medical school. That's my view, at least. I'd be interested if that's your view, and whether we need to address that and what we need to do in terms of teaching digital medicine, or whatever you want to call it, to our medical students.
I think we can do a lot more. I think most of medical education has tacked on the technology or digital bit as a kind of an add-on or a special study module, and they focused on, rightly so, on the traditional aspects of medicine around diagnosis, clinical communication, clinical reasoning, and such, and that without a doubt is necessary. And the hard bit is working out which part of the curriculum to shrink to match things up. I think the bit, I don't think it's reasonable to make everyone interested in AI and data science and complex statistics, but you do need to lay those foundations. And I think a lot of the foundations start in medical statistics. We need to make that area, that subject, much more interesting again. We need not just we need to actually show people how to do some medical statistics because the tools are now freely available. Back when I was in medical school, you would have to do it by hand, or you have to buy some piece of software to try to do it, and you have to ask a statistician. Now you can do it all in less than 10 minutes on your own computer at home, or even on your own phone. And so I think we need to be teaching people how to do this aspect of medical statistics, which will lead on to machine learning and such, if they wanted to. The other aspect, which I did do in university, which I back then I thought it was a bit of a waste of time, and I thought it was just something for interest, was about the philosophy of medicine, or the epistemology. How do you know what we know about science and medicine? And actually, a lot of what I do in data science and machine learning and AI is actually about the meaning and classification of diseases, conditions. What does a certain word mean? And we do teach our students what they mean, but we don't teach it in a standardized way. The reason this meaning is important is because machines currently can interpret patterns, but they cannot interpret meaning. The meaning comes from us. And so as a result, the meaning, I spend a lot of time trying to interpret what something means to me in a real world setting and trying to produce it in a machine readable format. And so I think we need to teach our students about classifications and ontologies. I think ICD-10, we taught things like ICD-10 and such as kind of codes in which like little dictionaries which you put into the back of the reference library. You only fish out when you need to find that rare word. We need to we need to treat it very differently. We need to treat these dictionaries and ontologies as something that sits within our workflow, within the things that we do. People do Google searches on Wikipedia now to help them write their essays and to help them go through exam questions and such without cheating, obviously. And people do that without thinking about it. We need to develop that aspect so that they can map out different things and databases that are constructed all over the world, which can store this information already.
Excellent. Thank you, James. Well, I think I'm going to draw this to a close. This has been a fascinating conversation. Thank you very much for your time. And bye-bye for now.
Thank you very much for inviting me.